here today. I would like to thank Guillermo and the campus to give us the opportunity to present today some talks about the management of autoimmune disease, as we do in Bordeaux. So I am Estibaliz Lazaro. I work in Bordeaux in internal medicine, and Christophe Richez is a rheumatologist, and he also works in Bordeaux. And we decided to talk today about arthritis in taking the example of lupus. So, as you know, we decided to talk about that because lupus arthritis is very, very, very frequent, and it is reported in more than 90% of the patients. It is most of the time the presenting symptom, and when you ask the patients who suffer from lupus, they always say that the most frequent complaint is arthritis or arthralgia. So, it's a very important point. The problem is that lupus arthritis is very, very heterogeneous, and the inflammatory symptoms are sometimes very difficult to distinguish between non-inflammatory myalgias or authentic fibromyalgia. And sometimes it can also present as array-like erosive arthritis, so-called lupus. It is sometimes a deforming arthropathy, known as Jacques arthropathy, and sometimes it can also be myositis. The problem with these patients is that really MSK involvement impairs the quality of life of these patients with chronic pain, deformities, and loss of function in daily activities, and especially in case of concomitant fibromyalgia.
So I'm going to talk about one patient we managed together with ST and a few of our colleagues. This one? Yeah. So it's a 20 years old woman with multiple synovitis in both hands, and they appeared few weeks after her first pregnancy. She has a familial history of autoimmune diseases. And when we saw her for the first time, we found some increase of inflammatory blood biomarkers, so the ECR, but also the CRP. And I have to say it's quite common in patients, even when they have lupus, to have an increase of the CRP when they have a joint involvement and when they have arthritis. So here is a picture of her hands, and as you can see, you have some swollen joints, but also swollen fingers. And oops. And when we try to do a diagnosis and we use some biomarkers, we found NAS titer. I didn't try. Above 320. That's the wrong way. So I'm gonna use this case to talk about the new ASIA-EULAR classification criteria for SLE, and I think they will publish them in Annals of Rheumatic Disease during the summer, but probably you heard about it these last few months, and I think these last 2 years. And you know, that's interesting because they decided to have an entry criteria, and this one will be ANA above 1 to 80. So I think we will have to talk about that because maybe it's too easy to, it's a too easy entry criteria. Of course, if you have a more likely explanation than SLE, you will choose this other diagnosis. You need only to have only one time a criterion to use it. You need to, we will use some points, and you can use only one time in the domain the points. And I'm gonna show you the criteria, but first of all, I would like to say these patients have anti-dsDNA, anti-SM, and a low complement. And here, That's the punch she got because she has 6 points because she has synovitis, and because she has synovitis, it at least 2 joints, more than 2 joints. But as you can see, you don't need to have synovitis to have 6 points. If you have already arthralgia and more than 2 joints, and a morning stiffness above 30 minutes, and I have to say it's quite common to have a morning stiffness above 30 minutes. Patrick got it this morning for 1 hour. And you know, I think it's very easy sometimes to get these 6 points, and it's not very objective. She also got points because she has a low complement and anti-dis DNA. So I would like to talk a little bit about the musculoskeletal presentation in lupus. And you know, I think Esti just talked about that, but 76 to 100% of lupus patients experience arthralgia, so joint pains at some point during the course of the disease, with or without sign of inflammation. For rheumatoid, it's very different than in rheumatoid arthritis. You can have patients exactly like in rheumatoid arthritis, but sometimes it's more picky. It's more difficult to be sure they have inflammation of the joints. That could be very mild synovitis most of the time. And it's mainly hands and wrists, sometimes the knees, and it's very difficult to do to have the joint effusion and to analyze the joint effusion, because most of the time you don't have a lot of liquid. It's quite symmetric, and sometimes you have diffuse myalgia, but it's very rare to have a true myositis with a very big increase of the CPK. And I wanted to talk about that because it's very rare to have patients with back pain. It's not rare. It's frequent to have patients with back pain, but it's not at all specific of the disease. I think it's not linked to the activity of the disease. But of course, when you have a huge fatigue, when you lost 10 kilograms of weight, when you have some myalgia, that's quite common to have a back pain. And you don't need to increase the treatment only for back pain. That's very important because that's a very common complaint by the patient. Most of the time in rheumatoid arthritis, when you have a patient with a joint effusion, during the clinical exam you can find exactly at the same place than the day before. And when the resident has to examine a patient, he can tell you where he found the joint effusion. In lupus, it's totally different. You have a fluctuation of the synovitis. So sometimes it's very obvious you have a synovitis, and 1 day later, it's a different presentation. That's why it's very difficult to have a very objective information. And of course, it's important for the clinical trial, because if you have a fluctuation of the synovitis, that could impact also the placebo response. So during the day and joint by joint. It's very subjective component to the determination of tenderness and swelling. And I'm going to talk an example with a clinical trial. I'm very surprised sometimes by the number of swelling joints in a clinical trial. Arthritis manifestations are generally more subtle in lupus than in rheumatoid arthritis, with a shorter morning stiffness. And you don't have any structural damage. That's also a very important point, because that means you can, of course, the patients want to have a decrease of their complaint, but it won't change the future of their joints if you take time to fix the problem. So how to better evaluate joint inflammation in SLE? So of course, sometimes the clinical exam is easy, and Jaku arthropathy, you have this deformity of the hand, but it's a chronic, non-erosive, reversible joint disorders. And with the time, of course, because it's not normal to have joints like that, you have early osteoarthritis. You can use MRI, but as you can see, sometimes in some patients, it's exactly the same description in lupus and in rheumatoid arthritis. So you can find some synovitis, tenosynovitis, and I'm going to describe more possibilities. You can use ultrasounds, and so we decide in my department with one of my colleagues involved in ultrasounds to check most of the patients with joint involvement. So I'm in charge of the clinical exam, is in charge of ultrasounds, and because we do also exactly the same thing for rheumatoid arthritis, we have a big experience about that, and I have to say it's very different in lupus and in rheumatoid arthritis. Most of the time when I find a synovitis in rheumatoid arthritis, my colleague will find exactly the same with the ultrasounds. In lupus, it's totally different. When I have a synovitis, I think I have a swollen joint. Sometimes with the ultrasounds, he cannot find anything. So it's a very different description. So I don't know, maybe I'm wrong with my clinical exam. Maybe it's not real synovitis. Maybe it's something else. Maybe it's vascular. Maybe it's the skin. Maybe it's, I don't know. And maybe it's a totally different pathophysiology in lupus and in rheumatoid arthritis. And that means maybe the target is totally different, and maybe you cannot expect the same response with methotrexate, with steroids, with new drugs. So I think it's a very important point, and we don't know much about the joint involvement in lupus. So here are some pictures from my department. So sometimes he can find, so it's Nicola, can find synovitis with a Doppler signal, or tenosynovitis. And sometimes it's different, that's a different description. It's not synovitis or tenosynovitis, it's a peri-extensor tendon inflammation here. And we found a paper about that, so it's already described. And some SLE arthropathy are characterized by tendinitis and tenosynovitis. It's quite common, the tenosynovitis in lupus patients, maybe more than in rheumatoid arthritis. So sometimes you have only tenosynovitis without synovitis. And that's a paper from the Leeds colleagues. And I have to say, we talked with Peter Conagan 1 week ago, and we were very surprised by his result. He told us sometimes you don't have anything with the clinical exam. You don't have any synovitis or tenosynovitis with ultrasound, and he can find with MRI some very interesting description of tenosynovitis. I'm a little bit critical about that because in rheumatoid arthritis, we don't use MRI because it's very, very difficult to interpret. You don't know what to do with your clinical management with this kind of result because most of the time you need to have a clinical presentation to decide what you want to do. And I think with the MRI, you will find some inflammation. You don't know what to do with it. So be careful with MRI. You can find some anthesal involvement, a little bit like in spondyloarthritis. And it's interesting to try to find some Doppler abnormalities in this anthesal level. So just to talk about this woman, I think at this time we decided to treat her. And here are the last EULAR recommendations for the management of lupus. So it's, I don't know, quite difficult picture to read. But when you talk about joint involvement, it's a mild form or a moderate form. especially when you have synovitis. So here the treatment, of course, you have the hydroxychloroquine. We can talk about steroids, and you can use methotrexate, but you don't have much studies about methotrexate, and we will talk about the other possibilities. So here is our slide about the treatment of joint manifestation. Of course, you need to use hydroxychloroquine. You can use only low dose of prednisone. You don't need to use more than 10 milligrams of steroids only for joint involvement. It's sufficient. If you don't have any improvement with more than 15 milligrams of steroids, that means it's something else. It's not a common joint involvement. You should be efficient with a low dose of steroids in this kind of joint involvement. So I have to say methotrexate is useful in synovitis, but maybe it's more difficult when it's not a classical synovitis. A few papers described the efficacy of methotrexate, especially to decrease the dose of steroids. Belimumab could be useful in this situation, and we will talk about that. Leflunomide, it's only one paper, but I have to say it's very difficult to use this drug in a young woman because it could be difficult to manage a future pregnancy. MMF and azatropine, I have to say I don't think these drugs are efficient on joint involvement. I think when you have a very intense lupus activity, because you have a huge fatigue, you have myalgia, you have a lot of inflammation. If you decrease the activity of the disease with MMF or azatropine, of course, you will have an improvement of all the symptoms. But if you have only a joint involvement, I don't think MMF and azatropine are efficient on these symptoms. Other potential treatments, so rituximab, but they try in one trial to show the efficacy on the joint involvement and they fail. Abatacept, same. Tocilizumab, I think it could be an interesting option in patients with classical synovitis, like rheumatoid arthritis, but it's a difficult drug to manage in the lupus context because you will induce very often a neutropenia. So at the end of the day, it's very difficult to use it for a long time. Ustekinumab, I don't know, we will see. They show some interesting results in the phase 2, but I have to be to see more data to be convinced. And baricitinib, because we use it in rheumatoid arthritis, and I have to say it's quite efficient in some patients. That could be an interesting drug, I think, in the future, maybe for patients with synovitis in lupus, exactly like in rheumatoid arthritis. For other symptoms, I don't know. For these patients, I don't know, I have the slides, so it's helpful for me. So these patients, it was a little bit difficult to treat her at the beginning because she wanted a second pregnancy. And so we decided to treat her with hydroxychloroquine and low dose of prednisone. And because she got pregnant, after the pregnancy, we decided to introduce methotrexate. And it was very important because at this time, I think she was taking something like 15 milligrams of prednisone because by herself. So it was a way to decrease the steroids. And I have to say, sometimes methotrexate is not very easy to, you have a lot of safety trouble, with adverse effects, and it's not very easy to support the drug. And so it was very difficult to increase the dose of methotrexate in this patient. So at the end, we decided to introduce baricitinib in the phase 2 clinical trial. So I don't know if she got, no, I know now, but at this time, I didn't know if she got the placebo, the baricitinib 2 milligram or 4 milligram, but it was very, very, very efficient. And all the synovitis disappeared. And 1 year later, I knew it was the baricitinib 4 milligram. I think it was very efficient in air. What did you saw air? Yeah. It was very interesting. So I would like to talk a little bit about this drug very quickly. And you know, in this clinical trial, they decided not to analyze as a primary endpoint the SRE4, but the disappearance of arthritis or the rash. And I was very surprised by the description of the population, and I don't know what you think about that, because they found the mean was 5 swollen joints. And I think it's not so common to have 5 swollen joints in lupus patients. So once again, I'm very surprised by this description. And I think that means sometimes when you want to enter a patient in a lupus clinical trial, you know, you have, it's easier for you to find synovitis, but it's not real synovitis. And because it's not real synovitis, it will impact the way you will analyze 3 months later the situation, because you are all very optimistic guys and you are sure your patient will get the drug. So 3 months later, if it was not a real synovitis, you will think, oh, the synovitis disappeared. And that will have an impact on the placebo response. So here they found, you know, a SRE4 response. And you know, the musculoskeletal domain is very important for the SRE4 response, because if you have an improvement of the synovitis, it's 4 points. If you have an improvement of the rash, it's only 2 points. And because you need 4 points to have SRE4, it's more important to have an improvement of the joint involvement than the cutaneous involvement. And when they analyze the skin and musculoskeletal response, they found a significant response. But if you analyze the swollen joints, as you can see, it's not very impressive. And even with the placebo, you have a decrease of the swollen joint counts. That's, I think, very surprising. And I think that means at the beginning, or maybe because plaquenil was efficient and they began to take the plaquenil in the clinical trial, or maybe also because the clinical exam at the beginning was not very good, and you know, they analyze differently after in the clinical trial. So that's it for this patient, and she's quite well now, without baricitinib.
So just to add some data about the treatments in lupus, what you need to know is that when you use an immunosuppressive treatment, it doesn't always control all the systemic disease. And this is a story of a patient, of a nice girl, 20 years old, who had a history of lupus nephritis during her childhood. She was treated with hydroxychloroquine and MMF for 10 years, and she was in remission. And she went to visit us because of arthritis. And so this patient, as you know, SLE affects multiple organ systems, and sometimes these organ systems are very, very independent. And then for this patient, with the agreement of the nephrologist, we decided to switch MMF to methotrexate, so she was really in remission for lupus nephritis. And a few months later, she started a new lupus nephritis, a class 4-1, justifying another lupus protocol. So she was fine with this protocol, and we got the renal remission. But the problem is that we saw the reappearance of arthritis under 10 milligrams a day of prednisone. And the problem was how it was possible to treat this patient who had a really lupus arthritis. She was already on hydroxychloroquine, and she she was taking very well her treatment. She had low dose of prednisone, but it was not sufficient to control lupus arthritis. She was already on MMF because of lupus nephritis, but she was not fine on arthritis. So we decided to add belimumab. As you know, and we know that for years now, in the BLISS study, what they showed, that especially for arthritis, belimumab performed very well and was significantly better than placebo. So we did that for this patient, and we obtained remission when we used belimumab as an add-on therapy for this patient. So as a conclusion, what you need to know about lupus arthritis and how we treat lupus arthritis in Bordeaux. So one of the important points is that joint involvement does not justify more than 15 milligrams a day of prednisone, and you have to taper this dose as soon as possible. And the other important point, is that hydroxychloroquine is the backbone of this treatment. And when you use immunosuppressive treatment, you have to take into account that all this treatment does not always control all clinical domains. And finally, you don't have to forget the management of osteoporosis in these patients. And what happened in case of failure to improve arthralgia or arthritis? I think that, as Christophe already said, you really need to better understand these symptoms. Maybe it is just osteoarthritis, maybe it is vascular involvement, skin involvement, or it can also be myositis, even if it is infrequent. So you really ask and need to check the symptoms and to be sure that it is really lupus arthritis. Thank you.